This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Epilepsia Open, published in 2026, titled Expanding the Scope of Pediatric Epilepsy Surgery, Access, Indications, and Outcomes in a Modern Cohort.
This paper is quite timely, Alara. We've seen the landscape of pediatric epilepsy surgery transform over the last decade. It wasn't that long ago that our criteria for surgery were quite narrow, mostly focal lesional cases. But this study, led by McLaren and colleagues from Mass General, really highlights how far we've come in terms of modern diagnostics and expanded indications.
Exactly. The authors evaluated 100 consecutive diagnostic and therapeutic procedures in a cohort of 62 pediatric and young adult patients. What's striking right off the bat is their philosophy. They consider all children with drug-refractory epilepsy, or DRE, to be candidates for some form of surgical therapy. They're actively trying to close the gap created by historical underutilization.
That's a bold stance, but it's supported by the data. Let's look at the how. They've moved away from the old-school reliance on subdural grids. In this cohort of 100 procedures, 36% were diagnostic stereotactic EEG, or SEEG.
And the remaining 64% were treatment procedures. For the residents listening, it's worth noting the diversity of epilepsy types they managed. It wasn't just unifocal cases, which made up about 53%. They tackled multifocal epilepsy in 24% of patients, generalized in nearly 20%, and even combined types. This shows that surgical candidacy is being redefined.
It really is. It's no longer just about finding a single lesion and cutting it out. The diagnostic tools, high-resolution MRI, functional techniques, and SEEG have allowed us to localize functional brain tissue and surgical targets with much higher precision. But let's get into the meat of the paper, the outcomes. Alara, what did they find for those patients where the goal was a cure?
For the 33 patients who underwent treatment with the goal of cure or resection, the results were impressive. They achieved an Angle 1 or ILAE 1/3 outcome, essentially seizure freedom or highly significant reduction, in 81.8% of cases at the 12-month mark.
Over 80% seizure freedom in a modern, complex cohort is excellent. It validates the use of these advanced diagnostics. But I think the most modern aspect of this study is their data on neuromodulation, specifically the RNS, or Responsive Neurostimulation System.
This is a crucial point for our audience. As we know, RNS is currently FDA approved only for adults over 18. However, this study highlights its off-label use in children as a burgeoning standard of care. In this cohort, for patients who received an RNS implant, 79% were classified as responders, meaning they had more than a 50% reduction in seizures.
And don't forget the super responders.
Right. 38% of the RNS group were super responders, with over a 90% reduction in seizure frequency. The median seizure reduction across the RNS group was 78% at 12 months. For a population that historically might have been told there were no surgical options because their focus was eloquent or multifocal, a 78% reduction is life-changing.
It really speaks to the shift toward palliative but highly effective options. The authors also mention deep brain stimulation, DBS, and laser interstitial thermal therapy, LIT, as part of this expanded toolkit. It's about matching the technology to the patient's specific network.
Speaking of the patients, the study also touched on access and equity. They found that their surgical cohort largely matched state and regional demographics. This is a significant point because historically, socioeconomic bias has impacted who gets referred for these complex evaluations.
That's an important metric for any high-volume program today. We have to ensure these advanced treatments aren't just for a select few. Now, let's talk safety. When we talk about expanding the scope and putting electrodes and stimulators into more children, the first question from parents and colleagues is always about complications.
The safety profile in this study was very encouraging. Out of the treatment procedures, they reported a surgical complication rate of 4.7%, which represented only 3 patients. Most importantly, none of these complications were permanent.
That's a key takeaway for the residents. Despite the complexity of SEEG and neuromodulation in an experienced center, the morbidity is remarkably low. It supports the argument that the risk of uncontrolled epilepsy often far outweighs the risk of the surgical intervention itself.
The authors also emphasize that these outcomes were achieved at the 12-month postoperative mark. While we always want longer-term follow-up, the 12-month data gives a very strong signal of the efficacy of this modern approach.
Let's dive a bit deeper into the SEEG aspect. The paper mentions that SEEG has enabled the evaluation of deeper or non-lesional foci with better safety than subdural grits. For the students listening, why is that so critical in the pediatric population?
Well, as the paper notes, children often have subtle pathologies or malformations of cortical development that aren't easily seen on standard imaging. SEEG allows us to sample these deep or bilateral areas with minimal trauma compared to a large craniotomy for grids. It's that precision that leads to the 82% success rate in curative cases we discussed.
And it feeds directly into the RNS success. If you can't resect the focus because it's in the primary motor cortex or language area, you now have the data from the SEEG to place your RNS leads with pinpoint accuracy.
Exactly. The study really frames RNS not just as a last resort, but as a primary tool for children who have failed medical therapy but aren't candidates for traditional resection. They are essentially saying that the scope of surgery is no longer limited by the boundaries of safe resection.
It's a paradigm shift. We're moving from can we cut it out to how can we modulate the network.
To summarize for our listeners, this study of 100 consecutive procedures shows that modern pediatric epilepsy surgery is safe, effective, and increasingly accessible, with an 82% seizure freedom rate for curative intent and a 78% median reduction for RNS. The message is clear. Drug-refractory epilepsy in a child should almost always trigger a surgical evaluation.
Well said, Alara. It's an exciting time to be in the field. The knowledge gaps the authors mentioned in their introduction are slowly closing, and studies like this one from McLaren and the MGH team provide the real-world evidence we need to keep pushing the boundaries.
That's all for today's episode. We encourage our listeners to read the full text in Epilepsia Open for a closer look at the specific diagnostic protocols used in this cohort.
Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Eris.
And I'm Dr. Alara. We'll see you in the next episode.